I'm coming to you from Gadigal land, which is part of the Eora Nation. I'd like to pay my respects to past elders, present elders, possibly most important of all, future elders. And that's not a trivial exercise in the current environment where we're moving towards hopefully a referendum on voice and the statement from the heart and acknowledgement of that, but also First Nations people as custodians of the land and understanding some of the fundamentals of climate much better than many of us do from the ground up. I think what I want to say to start with, why would we be doing something as part of Research Week on climate and health? It's my fundamental belief that medicine is a social science and that we forget that medicine is a social science at our cost. One of the pioneers of that approach towards medicine was actually one of the greatest biomedical scientists of the 19th century, Rudolf Virchow. And on which modern pathology is actually based. And yet this quintessential biomedical scientist believed that medicine was a social science and that doctors have an incredibly important role, as do nurses and all the other health professions, in advocating for society. Virchow was actually a political radical. He saw the food riots in Upper Silesia in the mid-19th century. He was one of the people who rejected the germ theory of disease when Pasteur developed the germ theory of disease, which seems extraordinary from a biomedical scientist of his day. And his argument was that it was too simple. Disease was much more complicated than just a germ causing a disease, a bacterium causing a disease. And of course, he was both right and wrong. When Koch discovered the tubercle bacillus in the late 19th century in Berlin, what Koch couldn't have known was that most of the people in Berlin of that day probably carried the tubercle bacillus, yet only a minority developed tuberculosis, the quintessential social disease. We know that there are determinants of health that go far beyond what we do as medical and health professionals. For example, female literacy is one of the strongest determinants of health, well-being, longevity in families in countries of low income where they're not educating young girls. And Taliban, ISIS, Al-Qaeda know this because they know that when they educate little girls, the society changes. So we as doctors, I believe, have two roles. One, of course, is to promote science and base ourselves on evidence. And the other is to understand the evidence that our social, psychological, and economic environments play in the health and well-being of our patients and the community at large. And we don't do enough of that advocacy. And there's probably no greater existential crisis at the moment than climate change. Small particulates in the air increase the risk of cancer, of coronary heart disease, of sudden death. We know that air particulate pollution, for example, is going to be worse with climate change and heat stress. And we know that that people who are at the most risk of health and disease live in areas where they're going to be more prone to heat sinks and or heat islands, I should say, particulate air pollution, and all the other things that go with climate change, not to mention food insecurity, drought, and what have you. And it's not just us, it's in a global environment, and global stress is going to increase the risk of war over resources. There is no greater challenge to the health, well-being, longevity of human beings than climate change at the moment. And we as trust, well, I'll say you, because now I'm a journalist, so I'm right down at the bottom of the trusted pack, but you lot are right back up there at the top in terms of trust in the community. We have to advocate, we have to agitate, and we have to get political over this, because it ain't going to change unless trusted groups within the community advocate for the science. And the science is clear. And that's what we're going to be talking about today. And I hope that you put in your comments and questions, and I will try and get to them. We're going to, each person on the panel is going to present from their perspective, and then we will take a panel discussion which I'll share questions and comments as we go. Our first speaker is Professor Nancy Baxter. Despite Nancy's background, the digital background behind Nancy, which looks lovely and sunny, Nancy, it's about 2 in the morning for Nancy because she's speaking to us from Toronto, or as the Canadians would say, Toronto. And Nancy is head of the School of Population and Global Health at the University of Melbourne, is Canadian, is a general surgeon, an epidemiologist, and a public health physician. Please welcome Nancy Baxter.
Thank you very much, Norman. And I really do very much appreciate being given the opportunity to speak today. As you said, this is an existential crisis, and I say that in the most clear meaning of the term. This is something that actually threatens our existence. So I think it's terrific that we're having this conversation. So I'm in Toronto. It's actually Toronto is how you say it. And I want to acknowledge the land that I'm on, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Wendat people. And it is now home to many diverse First Nations, Inuit, and Métis people. Well, in Australia, the average temperature has risen 1.44 degrees Celsius since national records began to be kept in 1910. This doesn't sound like a big change, but as we all know, we are clearly now seeing the impacts of climate change. And that's not just in a way that affects others. We are now other species, other places. We are now seeing climate change affect the health of Australians. And, you know, this isn't something abstract. This isn't something that we can deny any longer. It's something we actively need to do something about. Norman talked a bit about the impacts from a public health perspective. We can think of the impact of climate change in a number of ways. There are direct impacts. So, you know, obviously when we have extreme weather events, we have death, destruction, and forced migration of people from areas affected by the direct impacts of climate change. We also have heat-related death and illness, which are becoming more common. We then have the environmental impact of climate change and environmental degradation, increase in air pollution, changes in patterns of vector-borne, food-borne, and waterborne illnesses. And then we have the socially mediated effects, so the mental health effects of displacement, the forced migration, which leads to the decreased health of populations, and the aggregation of poverty, the increase in poverty due to the economic impact of climate change, which of course has a direct impact on people's health. So again, this is no longer a future state. This is no longer something that we can think of in something that someone else is going to have to worry about in the future. And currently, given the impact of the 1.5 degree Celsius change that we're seeing in Australia with, you know, the increased severity of bushfires, the flooding that we've just seen in New South Wales, the migration of vectors, so the Japanese encephalitis virus that has now come south in Australia. You know, again, we're seeing these impacts right now in Australia. And the impacts will only worsen. The impacts of climate change on health will only worsen as the temperature invariably will go up. So when we look globally, that's Australia. When we look globally, there are 30 million people around the world that are displaced each year because of climate change, and another 7 million premature deaths due to air pollution alone. We know that there are 900 million people currently in the world who are at risk of hunger, and we know that this could double due to climate change within by the mid-century. These are again existential issues that are affecting human populations and public health. Because the impact on health will worsen, we know it will worsen because of the die that's already cast by our actions today, or actually inactions today in terms of climate change. We know that the impact on health will worsen. So in the short and medium term, we need to accelerate the adaptation of our healthcare systems, enhance the capacity of our healthcare systems to protect and improve population health in this unstable and changing climate. Of course, adaptation will become more challenging as temperatures rise, and really beyond the 2 centimeter Paris Accord agreement, really it will be unsustainable. So mitigation obviously is critical. Stopping climate change is absolutely critical as well. Well, how do we adapt? Well, one of the first things is we need to make sure to include the impact of climate change on health in all of our policy. Health is often forgotten when we're talking about climate change, both in the public discourse and also in policy making. And it's really essential that it's really a core of all the policy that's made with respect to climate change in Australia and globally. And there also needs to be major investment in healthcare system adaptation. There's a lot of support for other industries, other areas that are affected by climate change. Very little is done for the healthcare system, and actually it's critical that more investment be made. The crucial role of adequate financing of this change and adaptation is really essential. We need to adapt our infrastructure. We need to develop scenarios of how climate change will impact on health and develop strategies to help mitigate those. We also need to develop capacity to action and be able to adopt and develop new technologies to be able to deal with this. And it's essential also to do so in an equitable way. Climate change will have and is having a disproportionate impact on low and middle income countries, and everywhere is having an equitable impact on Indigenous peoples as well as marginalized groups. So this impact is unequally felt, and sadly enough, adaptation is also going to be unequally distributed. So the adaptation of our healthcare system, there will be a gap that's developing and will continue to develop unless we do something about it, unless we ensure that these vulnerable countries and groups are protected and we ensure that their health systems adapt for them as well. This is really a code red for humanity. And it's really important both that we adapt the healthcare system, but also we become part of mitigating, becoming part of the solution to climate change. I'm sure Forbes will speak more about this, but our healthcare systems, if you put them together globally, all the healthcare institutions are the 5th most polluting nation in the world. So we really have to do something to get our house in order in terms of managing the environmental impact of our healthcare systems. But also, as referred to by Norman, and I hopefully will be able to hear from others in the audience, it is really key that we as leaders of the healthcare system, as leaders in our nations, physicians, nurses, all the healthcare providers, it's really necessary that we educate, we advocate, and we lead to ensure that it's clear that climate change is having and will continue to have an impact on health, and that we need to do something. We need to make a change if we actually want to be able to have a healthy life for the future. So I'm really looking forward to this conversation, because I think it's so very necessary, and really we all need to be talking about this. And I want to thank you for having this topic as your first research symposium in some time.
Thanks, Nancy, and lots of questions there, which we will come back to later. And if you want to make your comments, just go into the chat room to do that. Our next speaker is John van der Kallen, who's a rheumatologist and chair of Doctors for the Environment Australia. Welcome, John.
Thank you very much. Thanks, Norman. Thank you to the ACMD team for having me here today. I will share some slides to help with the presentation, but first I would just like to acknowledge that I'm on the land of the Awabakal people, otherwise known as Newcastle, and pay my respects to their elders past, present and emerging. So yes, I'm a rheumatologist, and I'm in Newcastle, and I have been part of Doctors for the Environment now for 8 years. DEA has been in existence for 21 years and really came about because there were a number of physicians were worried about the impact on environmental issues on our health. And now we know that climate change is one of the biggest issues affecting our health. So consequently, we've spent a lot of time advocating for mitigation against climate change. But to give you a little bit more background on Doctors for the Environment, our mission is really to protect health through care of the environment. And we aim to educate and alert our colleagues, patients, public and politicians to the requirement for a natural, healthy environment for good health. So, we need clean air, we need clean water, we need good, safe soils so that we can have healthy food. With the need to prevent and redress environmental degradation locally and globally, the need for a sustainable development that meets the needs of the present generation without compromising future generations. And this, of course, is one of the big issues around climate. And also the use of the best available scientific evidence as basis for decisions, and the precautionary principle where the evidence is unclear. And multiple times we've seen that has not been occurring. So Nancy's already outlined a lot of the health impacts of climate, and these are very well documented now. When I first started with DEA 8 years ago, I started keeping a bit of a list of the environmental episodes and events that were happening that were affecting our health. But I've stopped doing that because it seems like it's happening every day. You only need to read international newspapers as well as our own to know that we've got things like bushfires and smoke affecting our health, and flooding, damage to the reef, causing, changes to the environment in the ocean, as well as increasing acidification in the oceans, causing huge problems. And now we're also starting to see all the economic impacts. So, a lot of the people who were saying that actions to mitigate against climate change were too expensive, well, now we can start seeing that the impacts of things like flooding and damage to our coastlines is causing a significant amount of economic damage to our economies, but also has follow-on effects with our health. So Doctors for the Environment have been advocating in this space for a long time. There's so many actions that we've done. It would be impossible to do all in 5 or 10 minutes. But last year we did this in combination with the AMA and multiple other medical colleges. And we got together a letter and sent to Scott Morrison asking for him to prioritise climate change as a public health emergency. This advocacy represented over 80% of Australia's doctors, and yet we did not get an answer from the Prime Minister about this advocacy. And I guess that this has just reflected what has happened in this country for over 10 years, trying to get action in this space. So we're feeling relatively positive, or there's certainly been a change in the feelings around interactions with the government, with the change of the government from the last election. But we still need to see some serious action happening to improve the situation. And one of the things that we're really advocating for is a national sustainable healthcare unit, which can really coordinate many of the activities within health so that we can mitigate against the health impacts. And we're still at a time when mitigation can make a massive difference to our futures. Adaptation will happen, but we really need to make a concerted effort to get our emissions down as fast as possible. But DEA has done lots of other things, and we do write lots of opinion pieces and editorials that go into various medical journals and newspapers. We've visited many other politicians to inform them about the health impacts of climate change, and often people don't understand that there's a health impact. Again, the petitions, we have an annual conference, which I'll also highlight again later. We presented at Independent Planning Commission meetings to talk about, new developments for coal and gas, etc. public health forums on things such as coal seam gas. And this down the bottom here was one of the most exciting things recently, was during the election, where a number of our members even put messages on the side of their electric vehicles and drove around trying to highlight the health impacts of climate and why it's important for people to consider climate when voting. But there's plenty of challenges for the healthcare sector and for ourselves more widely. To reduce emissions is a real challenge, and we're seeing that even now Australia's emissions in the last quarter have still risen. So despite all the activities that have been going on in this country, we are not reducing our emissions nearly enough. We still need to convince and educate people that climate change is going to have a significant impact on their health. And one of the catch cries we had was really that caring for the climate is really caring for your own health. We need to accelerate the government action on climate. We need to think about adapting to our changing climate to prevent our future health. We need to consider protecting and further repair of the damage to the environment already. Biodiversity is also suffering due to human impacts, and we really need to protect our environment, really to protect all of those things like clean air, water and soils. And one of the newer challenges, I think, is greenwashing. You know, as people become more aware of climate, and businesses are as well, you know, people start to say that they're doing work in this area to reduce their emissions, but in fact are continuing to do harm to the environment and continue to have significant emissions. And this is something that we're definitely seeing from the fossil fuel industry. So I'm just going to give a little plug here for our upcoming DEA conference that we're having in Melbourne from the 2nd to the 4th of September. It's looking like a fantastic conference with lots of excellent speakers covering a number of different areas such as divestment and investment, education, trying to get the message across about climate and health. And finally, for those who are not Doctor for the Environment members, or but would like to be or become a friend of DEA, then you're more than welcome to also join and become part of the over 2,600 doctors and medical students who are now members of DEA and advocating in this space. So more the merrier, and the stronger our voice, the more likely that we can get some action for climate. So thanks very much. I'll leave it there for the moment. Stop sharing my screen. Don't know if we still have Norman here, have we?
And yes, you've got me. Can you hear me?
Yeah.
Can you hear me? Yep, good. Always get a bit nervous when we're doing these. Our next speaker is Forbes McGain, who's an anaesthetist and ICU physician in Western Health, and a strong advocate for action on climate change, particularly in relation to the healthcare system.
Thank you very much. Can you hear me there, everyone? Yeah, okay. Waminjeka, or welcome from the lands of the Wurundjeri of the Kulin Nation. I'm speaking from Melbourne. I'm an anaesthetist and intensive care physician at Western Health, and also links with University of Melbourne and Sydney, and I declare certainly an active member of Doctors for the Environment. Thank you very much, John. So the environmental effects of one doctor are big, and I've sort of been involved in thinking about how do I get involved in most effectively in dealing with the health effects of climate change. And although you could be a tree hugger and spend my time trying to prevent chopping down old growth forests, which I think is incredibly important, I realised that I looked around myself in the intensive care unit, in the operating theatre, and thought, we've got some work to do here, don't we? So then I got involved early on, as I sort of say, with looking at what carbon footprinting is all about. And I take my hat off to Scott McAllister, the third author in this group here, who I've done a lot of smaller work, and we'll just touch on some of that in a moment. But looking at what's going on within healthcare and how we can start to quantify what really is occurring and actually make the changes that matter most importantly first, and then work on some of the other things a bit later. And what was important, of course, working with our colleagues from Sydney Uni, Aranima and Manfred, we showed that, as Nancy Baxter alluded to there, with the global healthcare footprint, Australia's footprint is about 7%. So it's about half of all the agriculture, all those cows and sheep out there belching. We're about half of that, or about half of the transport sector, for example. So it's actually quite important. And it's similar to about 1.5 million Australians, everything they do, all their clothing or their food or their air travel and car transport, etc. Everything that they do is similar to what the Australian healthcare system is. So it is big, and it needs some action. And I'm just going to show you a little aside here. Here's just some simple stories of reusable and disposable equipment. There isn't actually much difference when you look at these things. In fact, they look almost identical. In fact, what we showed is the metalware here, for example, is identical. It's actually chrome steel, stainless steel in the same way. And I just wanted to allude you to, there is work going on, and we've got a long way to go, but you can actually make things, many more things reusable than what we currently do. Certainly at Western Health, there's been a lot of action in that regard, and we'll take you through the story fairly quickly, showing you how you can make a difference. What we did here in this life cycle assessment, so a comparison of all the costs, both financial and environmental, looking at reusable versus disposable anaesthetic equipment. This is all reusable at Western Health. This is all chuck away at the Austin Hospital and most other hospitals in Australia. So you won't walk into many hospitals in Australia that have reusable face masks or reusable laryngoscope blades or reusable circuits. There are a few out there, and I want a lot more there to be. The reason why we know that is because all the trainees come to me, all the junior doctors, and say, oh, this is so weird out here at Western Health. It's very different to all the other hospitals I work at, where it's all just discarded as single use. Now, what we wanted to do is show you that, in fact, what's going on here is the carbon footprint of reusable versus disposable that different? This was a study we published a couple of years ago now in the British Journal of Anaesthesia, and we went through the story of the life cycle of reusable and disposable equipment. I'm just showing you the back of house in the operating theatre. You can see work in action here of washing and disinfecting and then sterilising equipment. And what we did was work out behind the scenes energy use, gas and electricity, as well as time that was required for people to reprocess all these reusable things, because of course reusable equipment, most of the financial cost is in time, labour costs, as opposed to the single-use equipment, which is all about the purchasing costs. And we walked through the story over an entire year of work, actually. It was a lot of fun. It was very interesting. It was great to work and collaborate with lots of different people within anaesthesia, surgery, and very much so with the Central Sterile Supply Department, and Scott, our life cycle assessor. And just in a nutshell, what we showed was a bit disturbing emotionally to me, in that the reusable equipment, which is in the red here, the numbers don't matter too much, but the reusable equipment, if you're using Victorian brown coal electricity, actually has a footprint which is very similar, if not slightly higher, than the chuck away disposable equipment down the road at the Austin Hospital. And very different though, if you're based in, that's why it's green, in Europe. Yes, it'll be nuclear in La France, but elsewhere there's a lot of hydro, wind in particular going on. So your reusable equipment becomes much better if you're having renewable-based electricity. So that story for those, just a one little throwaway line is, renewables make reusables better. In other words, renewable electricity makes your reusable equipment so much better. You can't do that for the disposable equipment so much. You can't just reduce it by having reusable electricity for plastics, for example, because plastics are based on gas. So the fossil gas production, you can't get rid of that unless you move to bioplastics. And that's another story in itself that we don't have time for at the moment. But that is a story that shows you the actual electricity required in the manufacture of plastics. Even if you go to 100% electric, is only as small as about 20% of the story. Most of the story is about gas, which you can't get away from. So that's why it will remain with a high footprint. So what do we do from this? What was interesting is that we kept our reusable equipment because mainly for financial reasons. And this was a real surprise to all the Central Sterile Supply Department, as well as the leaders of the Operating Theatre Management Committee, is that the reusable equipment saved about $5,000 per operating theatre per year. So we were going to move to disposable like the Austin, but we said, no, we're going to stay with reusables because it actually saves money. We were surprised by that. And it saves our hospital about 100 grand a year. Now, if the whole of Australia went to that, reusables, you would be saving tens of millions of dollars for just one aspect of the operating theatre, which is anaesthesia equipment. So although it's not that exciting from an environmental point of view, it is from a financial point of view yet. And I mention that because change is underway, and it's quite exciting here. The state-based, as you can see, 2021, state-based hospitals are moving to 100% electricity generated by renewables. This is a big change. In other words, Victorian public hospitals and schools will be just like Tasmanian or ACT or South Australian or New Zealand hospitals, where their renewable electricity forms a much, much higher proportion of the total electricity generated. So it's quite exciting, very excited about that. And that will move us very quickly into that concept of renewables make reusable equipment better. So that little story I just wanted to decide is a big change. The other big story I wanted to have, this is a publication with Hayden Birch and other DA members actually, in the Medical Journal of Australia. This is just look at this section here, Victoria. This is public hospitals' total energy consumption. The red is electricity and the blue is gas. So it's really interesting, isn't it? That, well, I find it interesting, that the electricity is only half the story of energy for hospitals. And that's because you have to heat the hospitals in the winter months. So right now, we are just rampaging through the amount of gas that we're using in Victoria. That's because we heat overnight. It might be 2 or 3 degrees at night, but we warm it up to 20 degrees every night in winter. And so a lot of gas has been burnt. Bit different in New South Wales, though still a bit there, and very different, of course, in Queensland, WA. South Australia has a similar story to Victoria, except, of course, there's fewer people, so there's not as much gas being burnt. So what I would say here is we've got a lot of work to do here on getting off gas. So although some of us wanted a gas-led recovery, I think we need to get off gas. And a good example of that, of the real leadership shown on the part of the Western Health Board and CEO, is the new Melton Hospital that's going to be built on the western suburbs of Melbourne will be 100% electric, just like the new Women's and Children's in Adelaide, and the extension of the new Canberra Hospital obviously in Canberra. So we're excited that we're moving in the same direction now. And there's going to be big change ahead. And that was a lot of work on the part of DEA members, as well as excellent work by the executive to get that over the line, because it was not a fait accompli. I can assure you the new Footscray Hospital, sadly, will be built on gas. We failed there. We didn't get it going, but we're moving that direction now nicely, at least. And so we need to just keep that story going. So I think that's a big change. Now, I'm an intensive care physician. I couldn't forget about our friend COVID-19 and the land of single use. What do I mean by that is that Western Health has gone through more than 1 million disposable PPE gowns in the last year alone. So about 1 million per annum for the last couple of years. Now, that's just one healthcare system. We visited, we thought, wow, surely we could have reusable gowns. So we got together with infection prevention and infectious diseases, Marion Kainer, the head of the infectious diseases unit at Western Health, and said, can we do this? She said, sure, we can do it. Let's look for how we can do it. So Kirby White is a GP from Bendigo. Sam Bates is here as the ICU research nurse who came out with us. And we looked at how they were doing. Look up gowns for doctors, fantastic group. The GPs just didn't have enough PPE because the hospitals said, right, when we need it, start of 2020, COVID came, we need gowns. They couldn't get them. They got local seamstresses to make them. And so Kirby herself has gone through 10,000 reusable gowns herself, being re-washed rather than using 10,000 disposable gowns. And so that's really exciting story to how that has changed. Now, I won't mention the environmental effects too much there, but the good thing about gowns and washing is that these are not sterilised gowns. And so the carbon footprint of the reusable gowns is much lower than disposable gowns because it's just a disinfecting process. It's not the full sterilisation. But that's really exciting. What we then do, as we said, showing you something that's really rare, is me. No, it's not just that. It's the fact that in our ICU, we're now using reusable PPE gowns. We're using 10,000, we're using more than 10,000 a week at Western Health alone. Here's a reusable gown that is being used in a sterile fashion to insert a central venous catheter on a patient I didn't want to show you. But the main point is that reusable gowns are just the standard now at Western Health. So we're very excited about a change that has occurred promptly and is actually quite tangible. The nurses are very supportive. It actually is more comfortable to wear than the disposables. It also actually saves money, about $1.50 per gown that you use. So when you start talking about tens of thousands of gowns, well, it's tens of thousands of dollars. So here in the final summary, I just want to say that we're building a foundation of sustainability and the evidence and research base behind that. That's all really only happens in about 2005, but we need to translate this into practice well beyond islands of hope. And I think that this is where all of the team that's listening at the moment now is about. We need clinicians that can work with agency in their own level. We need hospital executive and boards to get off gas and go 100% renewable electric. We need colleges, the AMA, the Australian Nursing and Midwifery Foundation, as well as other allied health groups to really move and just say this is the standard that we need to move towards net zero. I mean, this is a race to net zero, as the IPCC quite eloquently labels it. And the societies and advocacy groups, I mentioned Doctors for the Environment, as well as the Climate and Health Alliance. And I think the other really important group that we're working with now is the Choosing Wisely group and Wiser Healthcare from Sydney Uni. Low value care just needs to change. I mean, it's just so jolly obvious that we shouldn't be providing low value care, and yet we still do. Healthcare policy and government commitment is really important as well to systematise things. And I think I'd really put a shout out there again that we need to coordinate things both from a federal sustainable development unit as well as state-based. New South Wales and Western Australia have this now. They're underway. Kate Charlesworth with New South Wales Health and Sally Forrest in WA. We need in Victoria to get there, and we need to get moving fast. So thanks for your time, and I hope you have a few questions at the end of the show. I'll stop sharing.
Thanks, Forbes. And I just encourage you to make your comments. Don't wait till the end. Make your comments whenever you've got them to make. I'm not seeing anything in the chat room yet. Don't be shy. Put it in. Our next speaker is Monique Ryan. Monique is Professor of Neurology, Pediatric Neurology at the Children's Hospital. But unless you've been living in a hole somewhere, closed over with thick concrete, you would know that she's retired from that position to become the member for Kooyong, throwing out the federal treasurer in the process as part of a movement which is largely based on, well, significantly based on climate change, but also integrity in politics, and the two might actually go together. Welcome, Monique. In you're still to be decorated room, office, I take it.
It is still pretty basic, I'm afraid, Norman. Yes, I'm waiting for some art to be brought to me. Not much yet, but it's a great pleasure to be with you all. I speak to you from the traditional lands of the Ngunnawal and Ngambri land, where I am actually working on the climate change bill, which is we're going to be debating the second hearing of in Parliament this afternoon, which is exciting. So I think my remit this afternoon, and thank you for the invitation to meet with you, my remit is to speak about the most disruptive political movement of our generation, of which I'm very pleased and proud to be a part, and how my role as a citizen, doctor and politician position me. I'll just do that briefly, and perhaps people will have questions at the end. Essentially, I came to this out of desperation and anger. I've spoken to about this at some length in public in the last 8 months, but as a doctor who was very much aware of the effects of climate change that we've been talking about for the last hour or so, I was feeling increasingly frustrated and powerless, which was what precipitated my movement to my standing as an independent for the seat of Kooyong. And separately, but simultaneously, as you know, a number of independents have done the same sort of thing and been elected to traditionally right-wing seats around Australia, and are now meeting in our nation's capital and plotting ability to affect Australia's response to climate change in the nation's capital, in Parliament. How does my role as a citizen doctor politician position me? It's interesting. Some of you might have seen me have a bit of a go at the Liberal Party yesterday about the fact that they're not wearing masks in Parliament. It's been interesting, actually, that I find that as a doctor, you are accorded respect in this place and in other places that you don't always receive in the consulting rooms of one's hospital. People do listen to doctors. They do respect our position about things. I've been able to, just in the last week, be elected to the Standing Committee of Parliament for the NDIS, but also that for health. And I'm really looking forward to being able to have an impact on the country's response to COVID, but also have a voice to the effect of climate change on health, particularly on children's health, given that that's my area of expertise, but also on other aspects of the ongoing and obvious effect of climate change on other populations within Australia and the extent to which anything that we do to ameliorate that will improve the health of our population as a whole. What I have seen is the power of community and the power of voices. And I think it's more clear to me now than it ever has been in my life that we do have more power as individuals and as communities and craft groups than we appreciate. We've seen that in the last 8 months, and I know that my community in Kooyong has been very empowered by the fact that community action has almost inexplicably been effective in getting someone elected to Parliament to represent us who is committed to immediate and effective action on climate change. We didn't think it was possible 8 months ago. When I put my hand up to run for Kooyong, I didn't think it was possible. It turned out that it was, but it turned out that it was also possible in North Sydney, in Mackellar, in Wentworth, in Curtin, in Fowler, in Goldstein, in Warringah, in a number of electorates around Australia. And so one thing I guess I would say to all of the people attending this meeting today is to never underestimate the power of the community, particularly of medical professionals, because although sometimes it doesn't feel like that when you're in the waiting room or in the clinic room and people give us a bit of a tough time about various things, people do still respect doctors and do respect their voice on only on healthcare, but also on matters like integrity and transparency. And so I think the groups such as the various medical action groups for climate change do have a really important voice. And I think they will have more of a voice and more of an impact and a presence in this 47th Parliament, which I've just joined, than they have in the last 9 years. And I'm very much looking forward to meeting with medical groups, doctors groups, other groups to work out how we can act locally, but act globally as well on climate change.
Can I just be clear, Monique, how much longer do you have before you have to go back into the House?
I think I can stay till 5 o'clock, Norman. I think it sort of depends. If there's a division, I'll turn and flee. And it's not clear if there's going to be a division or not, but you'll hear bells and I'll go pale.
Okay, I'll hold off asking you questions then, but yeah, I'll hold off in a moment. Okay. So thank you for that, and fascinating, and we will have lots to talk to you about. Tim Reid is also a politician and began his medical career as a sexual health practitioner, going back to the days of HIV, and also has been an activist in various ways, including the bad old days or good old days of Bugger Up. Welcome, Tim.
Thanks, Norman. And just checking, can you hear me?
Yep.
Great. I'll see if I can share my screen and see if that works. Well, hopefully you can see that.
No,
Not
we're not
yet?
seeing you. Shame's been shamed.
Okay. Well, look, I'm not going to stuff around with this. I'll just talk, and we can worry about the pictures another time. So I guess the key thing I want to do is talk a little bit about the my pathway to Parliament.
We've got you. We've got your screen.
Great, thank you for that. So you mentioned bugger up, and as a medical student, in the 1980s, I was involved in writing some health warnings on tobacco billboards, and this shows my age because back then there were tobacco billboards everywhere, including right across the road from the Children's Hospital. The reason for talking about this is because it gave me an interest in the process by which Victoria moved to outlawing cigarette advertising and how that required a consensus actually between Labor and Liberal health ministers and across the Parliament. And it really relied on some hard work by some individuals at both within Parliament and a lot of lobbying outside. Later, when working in the HIV field, perhaps 10 or so years ago, people who didn't have Medicare had no access in Australia to antiretroviral therapy. And I had a lot of patients from Africa and Southeast Asia, and we had to work on trying to get generic antiretrovirals like these imported from India. And that process of getting antiretroviral therapy for HIV positive patients who don't have Medicare took the best part of 20 years. It's only just very recently that governments have finally agreed to fund that. And that's a preface really to pointing out the importance of working out how to pull political levers to get political action in response to a scientifically defined need. And climate change is a scientifically defined need. Somehow, we saw political action within weeks in response to COVID. The entire economy was shut down in response to something that basically just shows up on a PCR. And yet we're not seeing the same sort of response in Australia or indeed in many countries, and certainly not in Victoria. So one of the messages I want you to understand is that the states are very important in both in climate action and inaction. And the bar chart on the left shows the percentage of electricity obtained from renewables. Victoria is about in the middle of the pack at about 1/3. South Australia is way ahead at 2/3. The ACT not shown here in Tasmania, both 100%. And but we're burning through a literal shipload of brown coal every single day in Victoria and scheduled to close our biggest power stations in 2040 or beyond. We're still drilling for fossil methane gas around the 12 Apostles. We're going to open up, unless we can stop it, a gas import terminal at Corio Bay. And Victoria is a state that's using 2/3 of the household gas consumption in Australia. And this is fossil methane. And if it comes from fracking, with a lot of fugitive emissions going into the atmosphere, it's just as bad for the climate as coal. We've just introduced a tax, a road user charge on electric vehicles. We're thrashing native forests before we phase out logging and finish it in 2030. And we're subsidising and funding production of hydrogen from coal, so-called brown hydrogen. We're even subsidising at a state level, and I think also a federal level, carbon capture and storage research, and we're subsidising an aluminium smelter. This just shows the energy consumption for electricity generation by state. Ignore the colours other than the black and the brown, which is brown coal and black coal, and the red, which is gas. This was on a very windy evening just on Sunday, just as the sun was about to set. So there's a lot of green showing a lot of wind power. The point is we've got a long way to go to get rid of coal and gas. And if you want to have a look at this, it updates every 5 minutes, and just Google NEM watch and you can see precisely what we're using to generate power at that moment. So politically, in terms of climate action in Victoria, you ask the government and they will say Victoria is leading the way on climate action, and they will almost always avoid saying the word coal. This year, we've got, after this week, 3 more sitting weeks, and then we go to an election on the 26th of November. Anthony Green predicts that Labor will win with a reduced majority. There's a narrative out there that Labor might be in trouble, but if you look at the makeup of the Legislative Assembly, you can see that Labor's got almost 2/3 of the lower house seats. They outnumber the Liberals more than 2-1. There's just 3 Greens and 3 rural independents. So Labor's not in a lot of trouble. Upper house, no one's got a majority, and there's a hodgepodge of micro parties occupying the crossbenches there. And so I want to just talk now briefly about how to influence government, given that we're almost certainly going to have a Labor government after the election. And I put together this hierarchy of fear, which is what I think government ministers fear the most in decreasing order. And they have greatest fear of the media. So if I get up and speak in Parliament, they're not there, they're not listening, they don't care. But if I get media coverage, they're quick to respond. They're also, I think, very much influenced by unions and big business, and to a lesser extent by nervous backbenchers who might be worried about losing their seats. So if you want to influence a politician and you happen to live in a marginal seat, talk to your MP. And they're also influenced by large groups of voters, or perception that large groups of voters might be moving on an issue. And I think we've seen that with the election of Monique and the Teals, and increased representation from the Greens in the recent federal election, showing that climate is obviously important. And so since I'm talking to a group of researchers, educators and clinicians who care about the climate, what can groups of health workers do? Well, obviously trying to influence ministers using that above hierarchy of fear. Building a media narrative is really important. It doesn't matter necessarily what the detailed facts are, but if the journalists have a kind of received wisdom, a sense that something is true, then it's very hard to shift. And I think we're also seeing that now with climate change. Meeting MPs in marginal seats, I've already mentioned, and speaking to supportive MPs who can do things occasionally in Parliament which do get noticed. But questions without notice really put ministers on the spot and are the things that media notice. So I'll just conclude by commenting about the coming election, which is to mention that if you can keep your issue at the top of the agenda, obviously parties are responding. It's very important, I think, for marginal MPs and candidates in marginal seats to hear from voters from their own constituents about fossil fuels, about coal and gas. I question the value of issue messages, whether it's vote for climate or vote for animals, unless they're connected to a political party. I'm not sure that they influence voters as much as campaigning for a particular candidate or party. And I said before, I think that they really have noticed the success of climate candidates in the federal election. So I might stop there.
Thanks, Tim. Obviously, major issues coming up. Monique, coming to you, given that we might be short of time with you. Will you talk about response? And certainly the success of the tools is really important. But I just want to reflect on COVID-19. We've just been through a pandemic. We're still in a pandemic. That's a salient point. We don't seem to have learned any lessons at all, just from where I sit, in terms of observing what's happened in the pandemic. People aren't wearing masks. Nothing's happening about ventilation. And that was an acute catastrophe to which we responded fairly quickly. And yet climate change is slow moving. So what hope have we got for dealing with a slow moving catastrophe like climate change? It will speed up, but it's slow moving at the moment, when we haven't responded appropriately to an acute pandemic.
That's a question for me, Norman.
It is.
Look, I think there's a certain degree of nihilism in the question. I don't actually accept that we haven't responded to COVID-19. I have many issues with the way that we have responded to it. I think that our response at times has been fairly adept, and at other times has been woeful. Right now, it's pretty woeful. And I think that's driven by a number of things, which include fatigue, uncertainty, and fear. But I think that will improve again, actually. I think at various times, the states in Australia managed COVID reasonably well. and then this new government is trying to get its head around what it needs to do. I think things will improve actually in the next 3 to 6 months. Certainly, there's a number of doctors in the new parliament, a remarkable number of doctors, particularly in the Labor government, but also on the crossbench. And we are all talking to, I've got a meeting with Mark Butler in an hour actually about COVID, and we're talking about ventilation.
I mean, my question isn't so much about COVID, it's about the politics of action when you see trouble ahead.
Look, well, I think what you have to do is you have to be pragmatic, and you have to accept that you're never going to get, a world-changing thing in one day. But, I think, tomorrow we will be, in this parliament, we will pass a bill that will legislate for an emissions target of 43% by 2030. Is that not enough? No, everyone knows that's completely inadequate, but it's a damn sight better than where we were 2 months ago. And we will get there, but it'll be incremental, and you have to be positive, you have to be forceful, and you have to keep trying. And the worst thing you can do is just sort of throw up your hands and say, well, it's never going to happen. It is going to happen. It will happen. It's not going to happen. It's going to be an iterative process. It's not going to happen as a result of everyone having some sort of road to, it's a Gethsemane moment where, where all of a sudden everyone realizes that we have to do this and we have to do it tomorrow. That's not going to happen, realistically.
Nancy, do you agree?
No, I think they're obviously very different situations, the pandemic and climate change. And in fact, we had very rapid initial response to the climate to the pandemic. And I agree with Monique that it has been this fatigue, and that hopefully things will improve in terms of our willingness to accept that the pandemic isn't over, and that, planning for the best and hoping for the best isn't the best strategy to move forward. The challenge with climate change is in part how kind of overwhelming and how abstract it has, I think, been to many people. And I do think now it's becoming less abstract. You saw the bushfires 2 years ago. You saw, the floods in New South Wales last year. You see Japanese encephalitis. You see all of these things happening. You see the bleaching of the coral. And in Australia, particularly, very vulnerable to the effect of climate change. And it is having an impact on health right now. So that with kind of, it seems, political winds starting to go the right way, I do think that there's an opportunity right now to make a big difference in Australia in terms of climate change. And I think, the physicians on this webinar and in the audience are really going to be key to that in terms of making sure people understand what's at stake and what is actually happening while we're watching and doing nothing. So I have a little bit of hope, at least, but I agree it's an existential crisis, and we need to move much faster than we are.
John, Monique talked about the power of community and mobilizing communities. Nancy implied that. Tim implied it too, as did Forbes. You're having, I would suggest you're probably having trouble in the DEA mobilizing even just the community of doctors. Let's just start there. How do we mobilize the community of doctors? Because as Monique says, if you do, it's potent.
Well, things have changed quite a lot in the last couple of years. I think as the severity of the drought worsened, we saw more people getting concerned about climate. And then we were struck by the fires when everybody was so affected by climate. And we saw at that time that in DEA that we got a lot more members joining up because people started to understand, what we were talking about. And then we had the floods, of course, and then we moved into COVID. So there's, implications with COVID and infectious disease, of course, with climate change as well. So the education around this and the realization that people are having is certainly bringing people more on board. And we're finding that we're getting younger doctors. We've got many more medical students who are involved in DEA as well. And they're getting very well informed about the situation and getting more proactive. So, I do have an underlying underlying hope, because when I look back at it from a few years ago, when, you know, if I wrote an article in the paper or so, you would get all sorts of criticism from every area. Well, that criticism has now diminished significantly. And I think that after we've gone through all of these climate disasters, that it's a pretty hard position to take, being a denier of what's happening. So we still have to work on doctors who are deniers, because we know that maybe there's still about 10% of doctors out there that do deny the science. And this is pretty similar to what we're seeing.
But are you giving, but picking up on what Monique's saying and Tim's saying, are you giving a political pathway here for people to exercise their views in a potent way?
Yeah, so we have a number of political asks, and we've had that for a while, and we've been visiting quite a number of politicians and getting the messages out there. So, you know, it comes back to that theory of change and how you do get change to occur, and certainly the politicians need to be part of that. And as doctors and medical students, we are a trusted voice. And it was interesting to hear Monique's comments from Parliament, because, you know, politicians and the general population do listen to what we have to say. So unfortunately, we can't avoid the political pathway. We have to do that, but we also have to bring the population along with us as well as our colleagues.
So Forbes, I know you're focused on the great presentation on the healthcare system and having an impact at the local level, but let's just keep the focus wide for the moment in this discussion, because at its essence, you're asking, if we're asking doctors to mobilize as a community, as a trusted community on a science-based issue, which is climate change, it's going to have to be disruptive. Can you get doctors to be disruptive? It's not of their essence. Their essence is conservative.
Yeah, people call me rather disruptive.
Can't possibly imagine why, but we'll go with that for the moment.
Well, yeah, because as you say, it's about change, isn't it? And there's a lot of resistance to change in many facets. I think there's also a lot of moral offset from doctors. I'll say that, in other words, I'm already doing good things. You're asking me to do more good things? Come on. So I think we have to be aware of those issues, as well as what Monique was saying, which is that there's a lot of burnout from not just doctors, but healthcare professionals, nurses in particular, over the last few years. But yeah, it is disruptive. I mean, there's no doubt it's disruptive. That's why it requires real effort, and it's not something that's going to happen overnight. It's something, you know, that you need to work at for a long time, and that's what the DEA and CAHA and other groups have been involved in this sphere for the last decade. But it's very hard when you've got, you know, so certainly, as you say, for the last decade, it's been nigh on impossible at the federal level. So that's why I've been working where I think I've actually led to real change in real hospitals, but now it's translating that out beyond us. I mean, if you take it to the nth degree, Norman, I'd love to stop the Amazon forest being burnt down, but you know, that's something well beyond my agency. I have agency within hospitals, and so that's where I focused, and it's led to real change. And I've been really excited by it.
But we're also citizens, and we may not have time or luxury to wait around. If the ice packs floating off Greenland and the tundra in Siberia is melting and releasing methane, we could be at a perilous tipping point. And as Tim presented a moment ago, and I'll come to Tim in a minute, it's shameful what's happening in Victoria and New South Wales.
Shameful is a strong word. You could describe it as that, but I think there's been real movement.
Oh, so just hold on a second, Forbes. You're willing to be disruptive in the hospitals, but when I make a political statement that might be disruptive, you're running away, are we? I'm teasing you here, but you know what I mean.
Never run away from it, isn't it? What I would say is, I think that there are multiple levels where you can act, and I agree that we as doctors need to do more. I won't deny that for a moment. I should do more. All of us should do more. I think you should, if I throw it back to you, you could have a climate change cast, not just the corona cast. So there you go, throwing right straight back to Dr. Swan.
Climate cast. I'm onto it. Tim, just outline what you think a strategy should be for, I mean, given that we are talking to doctors as a community, but also doctors are linked to community and have have the ability to mobilize a community. So in a sense, Monique's had to step aside as being an active doctor to do that. But can we do it while still in practice and out there doing what we do?
Yeah, you certainly can. And so, yeah, I too had to stop medical practice when I got elected. There just isn't enough. There aren't enough hours in the day to do a good job at either, if you try and do both, in my opinion. But I guess the first thing is that there's a reticence in some in DEA, I think, but certainly among doctors generally, to being labelled partisan for any particular political party or cause. There's a real hesitancy about nailing your colours to the mast. And I think that that's to some extent understandable, and DEA and organisations like DEA are influential when they make submissions to inquiries, when there are a group of experts and so on. And so I think that there's a need for, if you like, impartial bodies to be experts on climate and health. There's also a need for groups of doctors as citizens who won't back down, who will demand what is necessary for survival, for action. And, you can join Monique's campaign or next campaign, you can get involved with the Greens, you can, or I happen to get visited by two very nice DEA doctors who were lobbying me to raise the issue of a health sustainability unit last week. And I recognized one of them from an ad, the fossil-free ad campaign to a campaign to ban fossil fuel advertising, which is a fantastic campaign and a great ad, by the way. And I said, oh, is that a DEA thing? Oh, she said, no, we're doing that with Healthy Futures. So I got this sense that there are different organizations with different degrees of tolerance for being overtly political, and a little bit like the Sinn Féin and the IRA, kind of wanting the same thing, but one would play a little dirtier than the other. Sorry, Norman,
Nancy,
I didn't catch.
One's prepared to throw bombs and the other's not. I mean,
yes, exactly.
Nancy, just I asked a similar question I asked before, but of you, and also given your background in Canada, a very similar country to Australia. What are we looking for from clinical leadership? So we've seen clinical leadership from Forbes in changing in a very tangible way the footprint of hospitals. But what does leadership look like this moving forward when you've called it a code red for humanity?
So I think one of the challenges in healthcare leadership is you're always extremely concerned about the bottom line for today, and it can be very challenging to think about the future and perhaps to spend today to save tomorrow, or even just to improve things substantially tomorrow. So I do think from a healthcare leadership perspective, the urgency and the need for healthcare to be part of the solution just has to be more top of mind, or else you're always going to make decisions that are short-sighted and short-term in their natures. And part of that obviously is governmental, in terms of the government influence, at least on the public sector hospitals, to give them the room to be able to make these longer-term decisions. I think Forbes mentioned about Footscray Hospital, and that was really, really unfortunate, right? That decision was made. There are probably many, many good reasons why healthcare leadership made those decisions, but certainly the environment wasn't top of mind. So I do think we need to expect healthcare leaders to be acting for the benefit of the environment now. I think we need to make it one of the most salient things that everyone thinks about when they're making decisions that are things that are going to be in place for 10, 20, 30, 40 years and continue to be contributing to greenhouse gas emissions. I just don't think it's things that healthcare leaders have thought much about in the past. I certainly think that the COP26 signing on, if Australia had signed on in terms of making a commitment to healthcare emission neutrality, would be something that would really focus all of the healthcare systems, not just the public healthcare systems, on achieving carbon neutrality in the not too distant future. So I think that that's something very important that Australia can do.
And so looking at your backyard, you talked about adaptation. In your view, what so you've talked about adapting health systems to a lower carbon footprint. What other high priority adaptations can healthcare professionals contribute to?
Well, I certainly think one of the things we need to start doing is scenario planning. We had the pandemic and we have done some preparing for the pandemic, but we're going to be seeing more disease starting to become different diseases. In Canada, for instance, tick-borne disease is quickly coming further and further north. So places that would never have had tick-borne viruses and other diseases are now starting to have to deal with them. So we need to actually be very upfront about the fact that health is being affected by climate change, and start to kind of think about various scenarios about what's going to happen in the short-term future, so that we're prepared for them. Similar to developing pandemic scenarios. I also think we need to think about the mental health aspects of climate change and the disaster responses. At the school, we have people who do focus on helping children with resilience, but I think we need to think well beyond that, because I think in the near future in Australia, climate change is going to have a major impact on mental health. The disruption, the displacement, the major events, and the heat-related illnesses, I think, are going to have a major impact. So I think we do need to start focusing on mental health impacts of climate change as well.
Monique, what's been your biggest surprise since entering the House in terms of the agenda you want to pursue?
I think the extent to which the Labor Party is aware of the concerns that people like myself have, that their target is inadequate. I think they know it's not enough. They are willing to talk about ways that we can push them to increase our achievements in that regard. The challenge for me is to come up with, I'm developing an EV policy that would hopefully increase access to and decrease the cost of electric vehicles. But as an independent, that's a massive piece of work. And there's lots of challenges in writing legislation when you've never done anything like that before. But I think most people who are across the area know that we need to do more, and that our response to date has been inadequate, and that the government's current stance is political, not practical. It's based on pressures on them, not on their. It's not that they don't understand that we need to do more. It's just that they're holding back for their own political reasons.
And the other side of the House really doesn't matter anymore?
No, they don't. No, I don't think. I think they're going to be, they're not going to be part of the conversation in any meaningful or effective way for at least 6 years, probably more.
So, Tim, I'm sorry, go on.
So, the major challenge is actually possibly the Greens in terms of, with all respect to Tim, we're still not 100% clear how they're going to go in the Senate. And I think I know how they're going to go, but there is still the possibility that they might block the legislation on the grounds that it's inadequate progress, which I think would be a problem.
It would be a disaster. So John, in terms of moving to a mass movement, I suppose, is really, that's much more mobilizing. What are the educational tools that need to be pulled, or levers with doctors? I mean, should this become part of GP training, for example? Should medical student be required to have that as part of the agenda? the syllabus, I should say. So what need, in a crowded syllabus, but how do we, given that this is a health emergency, what do doctors need to know and how do we get them to know them rather than sensing as an issue?
Yeah, well, you're right. It starts at the medical school level. And over the last couple of years, DEA has actually written a fantastic document breaking it down into various system approaches so that we can show the climate impacts on health. So some of those things have been incorporated into medical schools already. So the University of Newcastle has a 4-week term during third year, where people have to study the climate impacts and come up with their own project and present that. So that's been fantastic, and many other medical schools are moving in that direction as well. But once people leave medical school, then they also they move into various areas of training. And this is where the colleges come into the picture as well. And we have been advocating with the colleges about what their actions are in the climate space. So for instance, next week we have our second annual webinar with AMA and ourselves, and we invite all the colleges to present just for a few minutes about what their actions are. So the College of GPs, for instance, has been very good. They have a whole gamut of posters that are available for waiting rooms to highlight to patients the climate impacts on their health. And the College of Physicians has a fantastic document about a similar area. And they're now starting further educational processes for its own members. So that, the College of Physicians, about 28,000 doctors, for instance. So it's working its way through the various levels of medicine. And I think that by doing that, then that's going to translate across to patients. So, every day I see patients and we have questions about how to improve their health. And a lot of that is about exercising to improve their weight and their blood pressure and their cholesterol, etc. But, moving away from using fossil fuel driven sources of transport and being able to be more active will help with all of those health issues, but also improve the carbon emissions from their activities. So this is where we have to kind of move in medicine as well. And there's so many great opportunities there.
And Victoria mentions in the chat group, let's not forget other allied health occupations as well. In other words, include the whole system there. Forbes, you've obviously done great work in picking up on what Nancy said, but cleaning up your own backyard first so that you're a beacon to other areas rather than being exposed to perhaps hypocrisy where you're talking about it and they haven't cleaned things up. One of the things that we're not good at is spreading success and spreading innovation. What's your strategy for spreading what you've learned? Because it's not good enough it just sits in Western Health or a couple of hospitals that have gone electric.
Yeah, that's very much the focus of my work now at multiple levels. So I think it's with members of the Doctors for the Environment. I think all those listening now need to just see if they could institute some of the things we're talking about now, or get in touch with me or others. Very happy to continue the conversation. I think that's why, Norman, though, we need a systematized approach. We need sustainable development units at the state level to say, these things, Norman, save money. I mean, that's the crazy thing about this stuff, is that it saves money as well. I'm very happy to talk about money, but it's very hard for me to walk into St. Vincent's or to Royal Melbourne Hospital or Monash, even just in Melbourne, and say, hey, what about changing some things there? At the Children's, it's all chuck away in the operating theatre still. And you think, well, why is this? I mean, this is a paediatric hospital. What's going on? And they say, well, it's difficult. So I think that we need to systematize it to make it normal. And so that's why I've been very focused on working with not just EA members, but also with trying to get sustainability units as part of the norm. But that's why we're having this conversation now, Norman. These people listening now, I'm hoping someone can take this away. We should hope for the best, but expect the worst. But we need it at multiple levels.
So Monique, when you were at the Children's Hospital, were you advocating for this sort of thing?
No, Norman, I wasn't. I was actually advocating for a whole lot of expensive rare disease drugs, one of which did get approved yesterday by Parliament in a happy coincidence. But No, I mean, I was just driven to the point, and then I jumped. And I think that's what happens with lots of people. And that gives me hope, actually, that I think, Nancy was saying earlier, people didn't believe in climate change, but over time it's become very apparent to everyone, unfortunately, through, lived experience, that we're in a climate emergency. And I think that's going to happen to a lot of people. That you get to the point where it's like, I'm not sure, oh, bugger it, I've just got to go do this now. That's what happened with me. And I think other people will be in the same situation.
So Tim, Mary Britton is saying, please hear the comments of those on the panel. Don't let the Greens be part of the problem. Your federal colleagues there repeating what happened 10 or 12 years ago with, 9 or 10 years ago with the
9 years ago.
With climate change, 9 years ago. So Tim, you talked about the changes with, oh, you got to go?
I have to go, I'm afraid my bells are ringing. Sorry, well, thank you for having me.
When your bells are ringing, you got to run. Okay, thanks, Monique. Right. All the best.
Thank you very much.
Thanks for joining us. That's
Thanks,
great.
Monique.
Thanks.
So Tim, just coming back to tobacco and the change there, because there are a lot of vested interests with tobacco. Probably an easier issue for doctors to exert change. Victoria did pioneer, it was the first, maybe was it first, maybe West Australia was the first, but essentially the first. Now, my memory is that it was Conservatives who led that. Nigel Gray at the Cancer Council led it, and essentially a fairly conservative, looking figure, but it was the Liberals, not the Labour Party in Victoria, that really pushed forward on this.
Yeah, so Labor was in power, but there was an influential Liberal health spokesperson name of Birrell, who was instrumental and reached out across the aisle to a couple of, because I think over the period of time this took, there were a couple of different health ministers. One of them was David White, another might have been Tom Roper, but I'm a little unclear on the details. It was a long time ago, but there was very much a cross-party collaboration in the process, and it wouldn't have been successful, I don't think, without that. And the Anti-Cancer Council, I mean, Nigel Gray's work and offshoots like Action on Smoking and Health, and then the underground movement, Bugger Up, and a related anti-promotions group called Mop Up, were all part of the change. And I guess what that illustrates is that there was multiple levels of activism and action, ranging from people in suits and ties in Spring Street, which is where I'm sitting, and people with spray cans in their hands at night, which was where I was back then.
Not sitting. So the question then is, again, in the lobbying power of doctors, how much traction in the current environment do you think there is across the aisle? And you're sitting in the middle.
Yes, well, right now there's not much cross-aisle action, I'll be honest, in terms of the Labor Party is very disciplined, and they have a pretty vice-like grip on politics in the state of Victoria. And I'm trying to say it be as objective as anyone can who is undeniably partisan. And I guess the relationship between Labor and the Greens is the worst in Victoria, from what I've heard from my colleagues in other states, compared to any other state or even federally. And so their way of working is to just try and shut us out of the action. Our way of working is to put things that seem like no-brainers on the table. And so, and it, sometimes we're successful and sometimes we fail, and sometimes it just takes a long time to be successful. So, for example, it's taken us 10 years of campaigning and about 3 private members' bills to finally get Victoria to agree to have a container deposit scheme, 10 cents back on bottles and cans. But it took just 10 days from when I announced a private members' bill to the government saying, we've had this great idea, for the government to say that they're going to remove the requirement for builders to hook new homes up to gas. So right now, if you build a new home, it has to be hooked up to gas in Victoria, if you're anywhere near the gas network. But the government announced 10 days after we said we're doing a private members bill, that they would do that. No reference to our bill, of course, it was all their own idea. So that's kind of how it works. There's a degree of sort of shadow boxing and so on. Whereas go to the ACT, there's a Greens Labor coalition in the ACT government, which is turning the ACT into the Scandinavia of Australia. So, and you know, they're 100% renewable energy.
So Nancy, just give us a sense of, I was trying to get, I went off on a tangent with you before, but well, not a tangent, but are doctors mobilizing in Canada?
They're starting to. You know, I mean, they are. I have a PhD student right now who's a surgery resident, who's very active in this area. Should be spending more time doing his PhD, but he's certainly very active. So I think there's a group of very passionate people, and they are organizing and they're having impact. So particularly in terms of trying to increase the sustainability of the healthcare system. It's early days, but I really do have hope, because I think we're just right now where a lot of different elements are coming together. There's the increased sense of urgency, the undeniability of this, and then the need for action. And I think the healthcare system is now understanding that it is not just going to have to deal with the effects of climate change, but it is actually a big part of the problem. So I would say many people in the healthcare system want to do something. They are starting to organize, and things like what Forbes has done, it gives people evidence, right? So I think that's another thing that's very important, is to actually have evidence that we can give to our administrators, that we can use to mobilize, that demonstrate things like, you know, cloth gowns are actually cheaper. Like, why are we using disposable gowns when it's actually cheaper and better for the environment? So when you actually have evidence like that, it really can be compelling. So I think that's one of the things that we need to do, is not just mobilize, but do things like what Forbes has done, and like set the foundation that people can use in their advocacy to actually make change. So that's what we need to do more of, in my opinion.
Forbes, you mentioned low value care. I mean, obviously that's a source of waste in the system. Is that all that that's about, or is there any evidence that high value care is good for the environment?
Yeah, good question. So I suppose because most of the focus has been on low value care, which by definition is either potentially dangerous in some situations or actually just of no good. If you look at high value care, so I mean, I work in intensive care, whether you call that high value or not, I mean, I actually think like vaccinations are probably the highest care value of anything we do, because of the number of lives saved for the least amount of money. So I think that's, you know, that's a fait accompli. I don't know if we know, if I hope I'm answering your question, Norman, but that's always going to be done.
Maybe I misunderstood your point. I thought you were making a point that for an environmental good, we should move to high value care.
Absolutely, yeah, absolutely, that's correct. Yeah. So I mean, and the problem is that there's a lot of low value care still out there. I mean, I work in intensive care and I see every day unnecessary pathology testing. And one of the work we've done is we've now, for the first time ever, carbon footprinted common blood tests like FBEs and electrolytes and things like that. And so you can now start to see, okay, there's actually a carbon as well as a financial cost associated with all this unnecessary testing that's being done in my ICU and in many other ICUs, and in fact around the country, in terms of millions of tests that are not necessary, CTPAs, etc. There's a lot of, and I think what I mentioned here, Norman, is that we've working with Wiser Healthcare, a Sydney Uni associated group, as well as Choosing Wisely, the national group. It's been found really hard to change doctors' behaviour to stop doing unnecessary low value care, partly for medical, legal, or whatever other reason. But maybe the story about actually carbon or environmental footprints could be part of the change that hasn't happened simply from showing that there's a financial benefit of stopping the use of low value care. A good example would be puffers. So the asthma puffers, they've got their own very high carbon footprints, a bit like some of the anesthetic gases I work with. The UK have just done a really nice study, a group looking at, you can actually get off the high carbon footprint puffers for asthma and get onto the dry powder inhalers, and at the same time actually not reduce the care of patients with asthma. So lots of opportunities in the future.
And of course, well, in fact, that's interesting. We could talk about pathology miles in general practice for all these little cars driving across town with 3 blood samples in them. An important issue. Lauren Sanders has wanted to put a question to each of the panel. If there was one practical thing each of us could do tomorrow as a start, what would you love to see? Tim?
So a practical thing that clinicians could do, I reckon, is look at use by dates. I think that there's a lot of single-use plastics like syringes or those, what are they called, Forbes, those resuscitation bags and mask things that they actually have use by dates on them. These are things that probably would last decades, but they have to be thrown out. Brand new pieces of quite expensive plastic. And I reckon an audit of those, how much money are we throwing out and what are the emissions from them? And could we do a 20% increase all use by dates by 20% or something like that and not kill anyone? I reckon that'd be a simple thing, and then publish it.
Yeah, I mean, they had an issue which Forbes would know about a few years ago, is can you reuse catheters and, in other words, single-use devices and actually reuse them, which created a bit of a fuss, but I'll come back to that later. So John, what would, taking up Lauren Sanders' challenge, what would be your...
Yeah, I already put a comment in there. Yeah, I think just using less fossil fuels in any way possible is really the key. You know, essentially, we have to reduce our emissions by 8% each year, year on. So there is ways to do that, and really looking at your own micro level of what you're doing, and you know, instead of maybe using the car, you know, every time, you know, 1 in 10 times you decide you're going to walk or ride your bike or do something. I mean, these are very easy things to do. But in healthcare, you know, as a rheumatologist, you know, I order imaging and things. And again, Forbes has done some great work looking at carbon footprint of imaging. And so, you know, an MRI scan is about 17.5 kilograms per scan, whereas an ultrasound is about 0.5 kilogram of carbon emissions per scan. So, you know, if I've got a patient in front of me and I need to image their ankle or knee or something, I could decide, well, I can probably get as much information out of an ultrasound as an MRI. So those kind of day-to-day decisions.
Which goes to low and high value care.
Yeah, that's right. So that's right. Absolutely. So
we need,
you know,
for that, we need data and data feedback to doctors and other health professionals as to what the cost, you know, just extending what Tim was saying, is that you need to know that when you order a pathology test, this is what you burn.
That's right. And there's a lot of processes in place there, you know, the evolve and the choose wisely kind of process have been going on for years, looking at low value care. But if they could incorporate the carbon footprint into those things, well, that would be fantastic, you know. And maybe even in the research world, you know, having carbon non-inferiority studies which involve carbon as well, so that if, you know, we're looking at new drugs, you know, you have to have a carbon non-inferiority component to that. You know, we don't want new drugs that are going to increase our carbon emissions, for instance. So, you know, it'd be nice to see that kind of incorporated into research as well.
So Narelle says soft plastic recycling. Andrew Cording argues that maybe hospital in the home is more carbon intensive than hospital in patients in hospital, which is a provocative statement and may well, you know, there might be some truth to it. So Forbes, what would be your one practical thing?
Yeah, if it's just one, I think that John's taken a good one, which is very important, is low value care. But I do think systematizing things. So I think that concept of sustainable development units, which in the UK have been shown to pay for themselves very quickly because of the financial savings that occur. So I think systematizing where is an ongoing journey to move to net zero. I think that's important.
Nancy?
So I think Tim brought it up in the chat, and it's not going to be popular, but I do think we need to rethink travel. And that's not just international travel, it's domestic travel too. We travel a lot of places to meet people that could be a Zoom call. I think international meetings are, it's great to be able to meet people in person, but it really is likely that we could get equal benefits without having to go that kind of distance. I am in Toronto, but it's the first time I've been in Toronto in 2.5 years, and I'm not here for a medical meeting. I'm here to actually see my mother for the first time in 2.5 years. But I'm not saying that we should, become hermits in Australia. But I do think there's a lot of travel. In my past, I've done things like gone from Toronto to San Francisco essentially for lunch, and we just have to stop doing things like that in the future.
So what are your main messages that you want people to take away from this? Tim? So
the first thing is that the states are very important in terms of being able to do good and do ill in climate change. A lot of people think of climate action, climate change as a federal issue. Not true. The states can decide when the big coal-fired power stations close. To give just one example. So I would look at that. And I think that, despite some of the things I've said, I think that if we want real change, and this is something I think Monique was alluding to as well, we won't get it unless we scare them. And we won't scare the major parties unless they see themselves as losing seats or likely to lose seats. There are too many powerful forces determining their agenda, which is more of an agenda now of not climate denial, but of what I've heard called predatory delay. Just agreeing that you're right, but doing things just a little bit too slowly.
John?
I think, again, that message that climate is going to impact on your health and is already impacting on health, and that we need to be active in mitigating against climate to improve our health, and that there's a lot of good solutions out there that will actually improve our lives, getting fitter, using EV bicycles, for instance, eating better food that has lower carbons, good for your health, reduces diabetes, reduces cancers. So, and we can save money along the way as well. So I think everybody just needs to get involved, and I guess that everyone being online here today is already involved because they've got an interest, but getting that message out there to those who aren't really engaged is really important.
And indeed, we've had very little drop off in the numbers of this meeting, so obviously there's a huge interest. John, Forbes?
I think that we all have agency. We work, I presume most of the people listening here are in the health fields, and we do have agency. A nurse on a ward, a doctor in the operating theatre, whatever it is, we all have agency, not just at the micro to make individual change, but more importantly at the meso and the macro. The meso being at your level of your department, saying, okay, we're going to use reusable equipment, whatever it is. That requires a lot of effort, but it can be done, and it's teamwork, and we're great social animals, and that's the way we've always dealt with crises as groups. And I think at the macro, and that's really engaging, if every surgeon or nurse or whoever else is listening here wrote to the CEO of St. Vincent's and said, no, we're not going to build a new St. Vincent's private hospital will be built on gas. No, we don't want that at all. Whatever it is, those sorts of things, very powerful messages, Norman, really powerful messages, micro, meso, macro.
Nancy?
So I think a lot of great points have been made. The one thing I would say is that, it's important in all of this that we don't lose the fact that climate change is not going to be felt equitably, and to try to ensure as healthcare professionals that we keep that very much in mind, and we try to do whatever we can to make sure that there's mitigation for those most at risk and most vulnerable, and also that all of us acknowledge that Indigenous people, so our Aboriginal and Torres Strait Islanders, who have a deep connection to the land, a deep respect for the land, and have lived in harmony with the land for 60,000 years, these are going to be highly affected communities by climate change, and that it's really our responsibility to make sure that we do what can be done to mitigate that.
Look, can I thank you all very much indeed. It's been a fascinating and a very important discussion. For some of the audience, it'll be a curtain raiser, and I'm sure there'll be people taking action as a result of this. At least I hope so, but I'm sure that looking at the responses there on the chat, it's a very engaged audience. And thanks to Megan for organizing this ACMD as well. Just, you know, a really great innovation. And thank you all. Go to bed, Nancy. You're up too late.
I'm going to have a nice sleep tomorrow.
Yeah, okay. So I'll hand back to Megan.
Oh, thank you very much, Norman, and thank you to all our panel members, Nancy, John, Forbes and Tim. I think you've really done a call to action. I certainly know at St Vincent's that our sustainability working group, I think, fell away during COVID, and they've looked at revamping it just a month or so ago. So we've got a lot of extra energy to put into this. And I think you're quite correct. It's now become an existential threat that we can all see through the horrendous climate, you know, disasters we're seeing. So I hope this is a call to action. Thank you all for coming, and thank you so much for your contributions for the day. Thank you. Been great. Thank you very much,
Bye, everybody.
Thanks,
All right.
everyone.
Thanks for the invitation.